Welcome to the Modern Patient Experience, a show about how U.S. healthcare is adapting to new patient expectations. I'm James Furbush, Director of Marketing at Access One, a company that empowers revenue cycle teams to help all patients effortlessly pay for care in full or over time. In each episode of this show, I interview executives from hospitals and health systems, physicians and nurse leaders, digital health pioneers, and others to better understand what it means to be truly patient-centric. The goal is to serve up new ideas, frameworks, and tactics that will help your organization give your patients the best clinical, financial, and operational experience. And away we go. All right, welcome back to the latest episode of the Modern Patient Experience. I'm your host, James Furbush, and my guest this week, I'm so excited to have her on. She is on the board of HFMA. She just joined the board of Haluna Health. She was a former chief strategy officer at Henry Ford Health System, Providence Health System, Alameda Health System. She's also done public health work for the state of Georgia. I'm so excited. Carladenise Edwards, welcome to the show this week. Thanks for making the time. Very excited for this one.
Thank you for having me.
Yeah. So I'd love to hear, just real quick, for our guests who maybe aren't familiar with you and your work, can you just talk a little bit about, being on the board of HFMA, your chief strategy officer work? What does that entail? And can you just give people a little bit more context into your career, who you are, and what you're all about?
I would love that. I recently joined the board of the Healthcare Financial Management Association, and I'm also on the board of the American Board of Internal Medicine, two associations that are in the healthcare space of really trying to bring together critical thinking around core issues. Everything in healthcare needs to be addressed, from the way it's financed to the way it's accessed, to continuing to use science and technology to advance treatment, right, and clinical protocols. And so between my association boards like HFMA and ABIM, my volunteer boards, Haluna Health, which provides direct care and services to the communities across the state of California, and then the public board that I'm on, Clover Health, I feel like I have my fingers in the different spaces. Right. And so my hope is that I have some level of influence or impact on how care is financed, how care is accessed, right, and how care is through my board service. That's what I did as a chief strategy officer, right, as I was always looking for strategies, ways in which to improve what we used to call the quadruple aim. And that work is still critically important and is carrying on in the fabulous health systems across the country. I'm looking at it from a different angle now, from the outside, kind of looking in.
Yeah. And so from the outside looking in, I think when we previously talked, you had mentioned those challenges of access to care and paying for care, the financing of care, are really that the overlap of that are two monumental challenges in the industry. And I'd love for you, just if you could just talk a little bit deeper about why you think those two things are such a big challenge that the industry really needs to address head on.
What's really interesting, if you travel globally or even you just read what's happening internationally, within the United States of America, we have some of the most advanced clinical protocols that there are. We have the ability to treat disease, right, to cure diseases, right, and to heal people who are sick, using all of the brains and the wits of people who come to the U.S. with the desire to actually heal, right, and to help people improve their health. What we're lacking is the ability for that technology, that science, the clinical care and treatment to be accessed and taken advantage of by everybody who needs it. And that's because our payment systems are not necessarily where they need to be, so that institutions can get reimbursed and paid fairly, right? And our insurance systems are not where they need to be to ensure that folks who fall into sickness and have ailments have the coverage that's needed to access the care. And so I feel like if we could just figure out a way to make sure that everybody who needs it can get it, then we could actually brag about how great our system is. But we have this really great system that's difficult for people to access. And it's not about reforming healthcare. It's really reforming the economics associated with accessing healthcare that we need to focus on. I really thought COVID, James, was going to be like this wake-up call that would get folks to start thinking about the fact that it's really important for every human being to have access to healthcare, right? Because the whole system broke down. Not sure we got the wake-up call, but we still need to start fighting or keep fighting, right? And keep moving forward on getting access to everybody.
Yeah. Do you think the COVID thing is interesting? Because I do feel like maybe it also is systems with better funds and ability to do, but I feel like there was a switch, not a switch, but like creating better access points, whether that's through like digital technology or having those protocols in place. I do feel like some of those changes were made. Certainly, we heard more about telehealth in 2020 than, ever before, which is really funny. But I do think some of those changes started to accelerate, certainly in the last.
Definitely accelerated telehealth, right? And the ability to have care delivered anywhere. And so to your point, James, I think we also accelerated or actually created ways in which to pay for and reimburse those services that did not happen in the traditional bricks and mortar. So that absolutely happened.
So, but can we level set on when we talk about access? Are we talking about just you approach it from that sort of physical bricks and mortar location? And when you talk about access to care, and obviously it runs the gamut, right? There's access to mental health care, there's access to just, complex surgery care. It really runs the gamut. But broadly speaking, how do you think, or how should we be thinking about when we talk about access to care? How should we be thinking of it holistically?
Yeah, let's break it down. So there's the first step, which is actually having enough providers available in the diversity of communities that exist in the nation, right? And so we have some communities that have just enough providers, whether they're mental health providers, primary care doctors, emergency room doctors, for the people in the community. There are other communities that don't have enough providers, right? There are not enough mental health providers. There are not enough primary care doctors. So access first starts with having enough people who can actually provide the care. And so there's a lot of work to be done to make sure that we can actually provide care with the clinicians that are available. One of the places that we need to focus on is improving our ability to have providers. And telehealth and telemedicine actually helps with that, right? Because you don't have to physically be in a rural location. You can actually be piped in, right, to that rural location and provide care. The other area of access, James, is around payment. If I can't afford to go to the doctor, I can't access the doctor, right? And so we live in a system and in a country where money talks. And without money, I don't get access. There are some places in our communities that provide charitable care. Most hospitals, nonprofit and otherwise, provide charitable care. But what you'll find is folks wait until they're gravely ill before they go seek care. Where had they gotten care sooner, we could have lowered the cost of the treatment and improved the outcome for that patient, right? And so when I talk about access, it's really because even though those providers might exist in a community, if the individual doesn't have the means, right, to pay for the care, then they don't get it, right? That's really the second big prong, right, in this access phenomena. So one is having enough doctors in the right places. And then two is having the financial means, a patient having the financial means to be able to see that doctor and not when they're on their deathbed.
Yeah, the financial, it's interesting because it's like, even if you in some ways have health insurance, it's like you don't have health insurance with high
Yes.
deductible plans and like cost sharing, which gets to be a very tricky thing. But I know for patients, that's certainly a, like a lot of people, it's like they'll get put off care until the end of the year when they know that like their
Yes.
deductible
Yes.
has been hit. And that's just for people who even understand their insurance benefits to begin with. How do health systems, I mean, you kind of mentioned charity care, but are there other sort of programs or ways that they should be thinking about that sort of financial component and working with patients, right? I mean, we've had like price transparency laws. Like we think, hey, if patients just know what they're going to owe, that'll magically solve this problem. And I use that word magically
No, I
sarcastically because I don't think it will.
it's going to cost, I might not go, right? If I'm
It's,
blunt with you, I might be more likely to go.
certainly, yeah.
Once you tell me how much it costs, I'm definitely not going now because I'm terrified of that. Yeah, I do believe that health. So, if we're speaking specifically to the health systems, there's some great stuff that health systems are doing, right? So, I do think transparency is important, particularly for those who have financial responsibility associated with their insurance product, so that they can choose the right facility and the right doctor and the right care to the extent that they can. I think the other thing is making sure that there are options, right, for payment and that we actually promote and let folks know, don't delay care because you're not sure how to pay or if you can pay. Get what you need and then we can work with you, right, on
Yeah.
settling up on the back end. I have this horrific story of a family member who went to the doctor and was turned away because his insurance card wasn't populating the system the way it should have. And they kept telling him he couldn't see the doctor. And I'm like, that's the wrong answer. The right answer is we will see you now and then settle up on the back end, right? With whatever the computer error is that was not accepting his insurance card or the cash that he could have taken out of his pocket and paid, right, for the appointment. And so I do think health systems need to think about what's the most important thing. Get the patient the care. We can settle up on the back end. And then I would add to that, there's opportunity, I think, for education. I think there's a huge opportunity for us to educate the public about how this really works. We all collectively and individually are paying for care that we're not getting. We're paying for the poor. We're paying for the elderly. We're paying for folks who are gravely ill and sick just by the fact that our employers can't afford to give us a raise because they're paying so much money in healthcare premiums, right? The mere fact that we're paying into Social Security and Medicare and high taxes, right, to cover the cost of the federal government and the state government giving out care. And so, whether you want to believe it or not, each one of us individually and collectively is paying for care. If we had an equalized system where everybody who needed it could get it, I'm pretty confident we could do the math and figure out how to reduce the burden on employers, reduce the burden on the federal government, and reduce the burden on individuals for paying for care that is unnecessary.
Yeah. It it's unfortunate that it's become such a politically fraught thing, the notion of paying for care and who pays for it. And, this show is not political, so we won't necessarily go there. But it is like the idea of paying for care and who pays for what. It's like no one is happy with
Right.
the current system. Like small businesses are not happy because they're paying an exorbitant amount of their operational budgets to provide health insurance for their employees. It's, health insurance as a business, it's not great for them as a business either because their margins are very tiny and they're squeezed on their end. And there's the public, paying, and patients aren't getting much. And, it just feels like no one is necessarily happy with the system that has developed. And are there like incremental things that can be done to get to a place where people are slightly less unhappy with?
Yeah, actually, that's a great question. I think we've made progress. We've had incremental change. We have to count the small wins, right, that exist. Is there more to do? There's absolutely more to do. There are a lot of companies that are out there that are looking at solutions and developing solutions that help individuals with payment, right? There are companies out there that are trying to streamline and improve the processes within healthcare systems and hospitals so that they're more efficient, right? And more resources can go towards clinical care and less towards operational care, right? And so there's work being done, but there's just huge opportunity in this space of what I would call payment reform or economic reform. It's really the financing of care that we really need to start thinking about and being really intentional about how we change this upside down pyramid.
Yeah. So when you say more about what do you mean the upside down pyramid
So
for
we
someone who's an idiot like myself?
we have a lot of money being spent and the outcomes are incredibly poor. Right?
Yeah.
I want to see really big outcomes, right, with fewer expenses.
Yeah. And do you think, is that like also funneling more money into social services? And it's interesting if you look at like other, oh, sorry, go ahead.
Redistribution, James. This is one of the things I think what happens is we think we need more and more. I think it's a redistribution, right?
Yeah. Because it's interesting when you look at like the spending, right? So one of the common refrains you hear is, well, the US spends a ton of money in healthcare and has really poor outcomes. And when you look at the spending relative to other countries, it's actually when you factor in like spending on social services and certain things, the spending is actually not worse one way or the other. It's just that other countries, say like France or other places, will spend more on the social determinants of health, primary care, keep people like from getting really sick and getting that sort of catastrophic care. And the US, maybe to your point, has it flipped, or maybe the priorities are backwards. Is that sort of what you've seen in your experience?
So, I can be really dangerous in this topic, right?
Okay, I like it. I'll let you be dangerous.
I'm spending my time studying this and trying to get a better and deeper understanding because I believe our cursory understanding is also contributing to our inability to solve the problem. Who spends the money is different in the United States, not necessarily how much money is being spent. And you're absolutely right, James. Where and how we spend the money, right? What we spend it on is very different in the United States, right? Which also contributes to the problem. So I'm going to use one of the things I've been thinking deeply about, James, is the fact that we believe there's going to be this cliff associated with Medicare spending as the baby boomers age and we have more people in need at the higher age spectrum, right? And I really started thinking about this the other day because there's some data that shows that people in our current communities and societies between the age of 35 and 55 actually have more comorbidities and health problems than those who are 65 plus. And so it raises the question around, do we need all of those resources attributed to treating people who are sick as they get older? Or will they need something else as they get older? And will there be enough for those of us who haven't aged into Medicare yet, but are really putting a burden on the system, right, as a result of our poor health status? The question, though, really is, are we putting a burden on the system? Because those of us who are in the 35 to 55 are not drawing on public benefits, right? We're having to manage our own health with the insurance products we either have or don't have access to, right?
Yeah.
So part of the reason that COVID hit us so hard was because that preponderance of people were so unhealthy. We didn't have the stamina, right, to fight the virus, the infection, and the disease, nor did those who are at the upper end of the demographic shift, right, our seniors and our elders. And so what if we actually spent some of that money on trying to improve the actual health and well-being and prevent that disease in the first place? Would we need to have this bolus of money sitting and waiting just in the event that people got sick? Couldn't we spend some of that money to help prevent people from getting sick in the first place, or to help improve the health of those who are suffering right now? And so I don't have an answer, but I think there's some really critical questions that we could ask ourselves about what resources are available, whether they're paid for by individuals, whether they're paid for by corporations through the insurance premiums that you talked about earlier, or we're paid for through taxes. Because we're spending a lot of money in those three buckets. That's what's different from some of our European countries that have what they call a single payer system. There's only one entity paying. It's the government.
Yeah.
We have multiple entities paying right now. So I don't think it's fair to say we spend less or they spend more. You know, it's not apples to apples.
No,
right?
Certainly not, given the private public nature of
contributions. Yeah.
But so jump back to what you said, which is interesting, which is looking at the money set aside for Medicare 65 plus, which actually maybe that population. So this study is suggesting the data says that they actually might be healthier than 35 to 55, which is, as someone who is in that 35 to 55 grouping, makes me a little bit sad. But is it that like our payment mechanism system needs to be more flexible, right? So it's a little bit like, I guess the question is, how do you shift the funds to better support the people who actually need it, not based on like you hit a certain age milestone, but it's really like, how do you get right? Because there's always that like 80-20. I don't know how true this is, right? Where it's 80% of the people or 20% of the people use 80% of the costs, or whatever that stupid, and I don't know if it's actually true, but the directional point is that there's maybe a small amount of people who have comorbidities that are using the most amount of care.
Yeah.
And how do you redirect the payment mechanisms and funding to basically help that population versus the people who are not necessarily using the system?
Yeah. I think that's such a great point, because, one of the things I think about is, if you're going to live, your desire is to live well, right?
And I should hope so.
Right.
One of my biggest fears is not living well and, being a burden on like my family and friends and sipping food through a straw when I'm 85 or 90.
Exactly. And so that's the point that I'm trying to make, is maybe we should be focusing on how do we use those resources to ensure that people can live well, as opposed to living long. Right. And so if you have a higher propensity for health and well-being, you're probably more likely to live longer. Right. But there's a whole bolus of people who are suffering from a physical ailment or mental ailment. And then you add the financial burden on top of that. Right. Is there something we could be doing for that population, that community now, so that they're more productive, right? They're happier, they're able to contribute in meaningful ways to our communities and our society. And so I like the way you said that, which is thinking about redistributing or thinking differently about how we spend the resources that we have for those who need it. They're just strategic questions that I think are worth pondering as we re-engineer how care is accessed, meaning how we pay for it, right? And then how many providers we need in the different spaces to deliver it.
Yeah. And so if you're a health system right now, thinking ahead to, we know healthcare moves slow, but let's just say into next year and over the next 3 years, what would you advise them should be their priorities in terms of creating that sort of access for the communities that they serve and ensuring that their patients can actually get in to see them, see the doctor, get the care that they need, how they want it, when they want it, etc., without worrying about the financial
cliff?
I don't want to say ramifications. That's not necessarily the right word, but I do think there is if you get care, you still have to pay for it. And a lot of that does fall to patients who have to make that tough choice of, look, do I want to get this surgery? Do I want to put food on my table? It's a very difficult financial macro environment right now that we live in with inflation and patients and things like that. They're making hard choices. And so if you're a health system, and how are you thinking about, how would you advise them to think about over the next year to 3 years, like what do they need to be prioritizing in order to better balance financial experience with the access to care?
It's an excellent question. One is double down on the services that your team is exceptionally good at and the community needs. So if you're a hospital-based system that is killing it in terms of orthopedics or cancer, do that. Do it exceptionally well. Maybe get to a point where you can do that in a manner that's less expensive than your neighbor, your competitor, that gives you the ability to lower the cost and increase the volume. If you're a primary care practice or clinic, nail that, do that exceptionally well. And see if you can get to the point where you can use digital and virtual solutions to extend access at a lower price point, right? And maybe take out your competitor. I think what we need to do for these health systems and groups is really double down on trying to be the best in your class. That puts you in a position to have higher volumes at lower rates with better outcomes. It's what we do in all the other industries, right? And so if we could do that in healthcare with the proliferation of technology, right? And the digital solutions and the virtual care and the telehealth, James, that we just talked about earlier, think about how many more people could have access.
No.
If a hip replacement isn't as expensive because all you do are hip replacements and you're nailing it, and it's cheaper for me to fly from, I don't know, let's just say Arkansas to Detroit to get my hip replaced by a surgeon who has stellar outcomes, I'm going to do that, right? Because I know I'm going to get a good outcome. I know that the price point is good and that you've been able to do this at scale, right? And so I do think critically about how do we create the verticals that enable us to make sure that the entire system is whole with all of the component parts functioning optimally. Right now, what we're doing is what I call peanut butter, which is health systems are trying to get bigger so that they own and control all the component parts, but at the expense of doing anything.
Yeah, but it also that requires a little bit of a mental shift. So if you're the health system, it does require you to think less about sort of market competition and more about, right, if you're the best ortho knee surgery, right, like in your market, maybe you're not the best, your geography, you're not the best like heart surgery, let's say, for instance. But maybe the health system down the street is. And so it does require a little bit of a mind shift to go from we're competing with them down the street for patients to we're working with them, competing against them. We want to send heart patients there if we know that we can get the knee surgeries here. But that does require a huge mental shift on behalf of the leadership to buy into that.
And it also requires what I call not just the providers and clinicians to think differently about the relationships with each component part in the system. It also requires the aggregator, right? Whether that's the managed care company, the insurance company, the population health company, to ensure that they're helping the patients, the consumers, get the right care from the right provider, right? Without missing any gaps in the coordination, right? So the entire person can be treated well. And so it actually almost creates a new business for the health system, right? And a new business for the provider. The provider is providing whatever care they're specialized in exceptionally well, and their market is bigger than the geography around them. Right now, the market could be much more global. The health system is serving as that aggregator, perhaps care coordinator, that helps patients navigate to getting the right care at the right place at the right time. Some of our commercial and what we call disruptors have been trying to do this work, right? You have the Walmarts of the world and others where they've said, you know what, we're going to find the providers across the country that are the best at X, and we're going to send our employees there, right?
Yeah, Walmart does that exceptionally well I think they've got deals with Cleveland Clinic to do the heart surgeries. And then I think it's like Virginia Mason, or they have someone for doing like ortho stuff. And I'm probably getting it wrong, but Walmart does that exceptionally well.
And so the point is that if there's an entity that can help the consumer, that patient, identify the best resource for their condition, the entity that can be that resource, that can do it at scale, now can make money off of volume and not have to do it by charging the maximum amount, right?
Yeah.
For the individual service that may not be done but once every blue moon. So the question you asked me was about how do we change this financial dynamic? And so my response is by getting us to a place where we actually can continue to make money, be profitable, but doing that because we have better outcomes at scale, right? As opposed to trying to do that incrementally over the peanut butter spread of multiple things being done at the highest cost at risk of not having the best outcome.
Yeah, it's interesting because where my head goes almost immediately, it's like re-envisioning the U.S. healthcare system as essentially like a supply chain issue, right? Because it's if you think about, say, like the global supply chain, right? There's companies out there that are just very good at making computer chips. They're the best.
That's what they do.
Fabrication, and they sell to Samsung or Apple or whoever. And they create very good businesses. They're not trying to make the whole phone, and they're not trying to make every component part of the thing. And it's interesting to think about like U.S. healthcare, sort of an analogy in that way. But
I usually use the car industry as the example, right? where there was a time where Ford, the motor companies, thought they had to own, manage, control every part, right, in the manufacturing of the vehicle.
Yeah.
And we failed miserably in that. When we finally realized, well, maybe the Japanese can make the glass, right? The tire companies can own and manufacture the tires. The Italians can make the leather. We were able then to reduce the cost of making the car to create scale in the manufacturing process with a nice brand, right? Based on design, right? And consumer preferences and outcome. Not that I want to make or equate human beings to little robots, computers, or iPhones, but to be candid, our bodies are machines. And our bodies are not functioning optimally right now. We're not functioning optimally. With that data point I gave you, that 35 to 55, we have more comorbidities than those who are 65 plus, right? Because if you think about it, given the fact that life expectancy has decreased significantly as a result of COVID, it's a big deal to live past 65. Right? So you must be doing something right if you made it that far.
The stats are, can be alarming too. I think it was like white males who are dying younger. And there's all sorts of, you look at some of the data points too, and you're just like, is this the system that we want? Or, and it's not, frankly. I don't think that, it's not. There needs to be a better way, but it sometimes when you think about the changes that need to happen, it's hard to think about what are just the incremental changes we need to make now to start somewhere. So
to answer your question, I think what I would say to any health system leaders that are listening is, and I used to say this all the time to my team, what's the business that we're in and what's the problem we're trying to solve? Right? Solve that problem, be in that business, do that thing exceptionally well so that you're in high demand. The challenge with this is nobody ever wants to be sick. Nobody ever wants to be ill. But you do know this, James, when you are sick or you are ill, you are injured, don't you want the best? And don't you want that at the lowest cost possible?
It's so hard because I think sometimes, yes, I want the best. And it, like, depending on what the condition I have would be. The hard thing is, I think I don't necessarily want cost to factor into it.
Oh,
right.
yes.
If I have whatever stage 4 lung cancer or whatever that is, I want to assuming I want to get the best care, knowing that I want someone to be able to help me live. And I don't know if it necessarily, I think for me, it's like, would I pay whatever to have the outcome of absolutely. The challenge becomes when you get the bill afterwards. Oh crap. Did I just saddle my family with a horrible burden because I chose to live? That is a hard thing. And I think, to put patients in that scenario is really difficult because it's like the care doesn't end after the exam room. Right. There is still that component of they have to pay for care. If health systems are providing care, it sounds bad, but patient revenue still matters to the bottom line of a health system. If you're a publicly traded health system, it's not to have it all be financially based, but it does become a challenge because
nonprofits and the tax exempt, you have to have enough money coming into the system in order to support it. So you've raised a completely different conversation, a different topic, which is a values conversation. This is a values conversation, right? In our country, no one wants to pay. Nobody wants to pay.
Yeah.
which is why it's so bifurcated, right?
Sure. Someone has to, ultimately, at the end of the day. I mean,
it doesn't matter if it's a public system or if a private system. It costs in a capitalist system, right? Anything, whether it's this ink pen, right, or my primary care visit, there's a price associated with the delivery of that service.
yes.
Someone has to pay the price, right? What we have in the United States is a lack of interest in anyone paying the price. And so we're constantly punting and kicking the can, right? And so as opposed to
describe it as
manning up and saying, okay, there is a price associated with the delivery of that care and that service, and someone has to pay it. And then determining what the best path forward is that's in the better interest of our global economy, we just keep kicking the can.
Right.
And it's a values question. And you actually raised something for me I hadn't really thought about, because when you said, I don't want to pay, I thought about it like this. I actually don't really want to pay either, but I have a very different outlook on these things. So I had this conversation with a friend recently, and we were talking about French fries. And it was, if the doctor told you if you had to stop eating French fries in order to live, would you stop? And my friend was like, absolutely, I would stop eating French fries because I want to live, right? And I would say, no, not necessarily, because living or dying isn't what scares me. Being ill or physically disabled scares me. So if the doctor said to me I had to stop eating French fries in order not to be disabled, I would stop. But if he said it was to keep me alive, no, I'd keep eating them until I died, right? Because in my mind, death isn't as scary as being disabled.
Right.
In my friend's mind, death is much scarier than being disabled. We have very different perspectives and views on life, right? So part of the challenge we have in this country is that, which is the thing that we love about the United States of America, the heterogeneity of it, right? And the diversity of it also creates values misalignment when we need to make really difficult and critical decisions.
Yeah, it's tough to factor in the needs and wants of those different, the needs and wants of different organizations. It makes me think of, we had a previous discussion on health equity, and they were saying, this guest was saying, you can look at one data point and say we need to reduce X services, but in doing that, if you dig deeper, you realize that a certain population might actually not be using the services at all and need it. So by reducing something, you're actually harming a subset of your population because now they're absolutely not getting it. And so what he was saying, it makes me think of that, is that it's like you need to be able to dig deeper to figure out all the needs of the different populations and factions that you're serving in order to really be able to, with a scalpel or fine tuning, be able to deliver what they need, which is a really challenge when you have such a diverse population here in the United States, from different communities who are not getting care, different communities who have access issues in rural places versus, city center populations. And that certainly becomes a huge challenge.
Yeah. And to your point, I think the access issue isn't just one in terms of whether or not people are able to pay. There's also the question about whether or not people are willing, right, to pay. And so I think it raises the question around what is the problem we're actually trying to solve for? And it's cursory to say making healthcare affordable or accessible. I think it's a little bit deeper, and I may not have gotten there yet, but much more sophisticated to say we need a healthier society, or we need a healthier community, right? Or we need more productive citizens. And then if you say that, then you can back into, now what do we need to do as a society or a community to get there, right? Because just saying making it more affordable doesn't necessarily solve the problem of, I don't really care how affordable it is. I don't really want to pay for that.
Yeah, I think we've seen this, right? From a health community standpoint, just look at, it's taken almost a generation. I feel like almost no one smokes cigarettes now. And maybe that's just like the buckets that sort of universe that I inhabit. But it is almost more of an anomaly now when you see someone smoking a cigarette. You're like, oh my God, there's someone smoking a cigarette in public. Versus a generation ago, it's like people were just lighting up cigarettes in restaurants, on airplanes, and the whole thing. And arguably, that has probably done more benefit for the health of the country and population at large by making it so that is an undesirable thing. And so to your point, I think, part of it is just figuring out what are those things that are really going to move the needle on the overall health and wellness and well-being of the populations, and really putting programs in place to move in that way. One thing we will not disagree on is giving up French fries, because
I'm not giving up fries.
That is, I am not giving up no matter what. Like fresh McDonald's French fries, oh, forget about it. There's hardly anything better in this world. I don't care how fat they make me. I have not given those up.
Right. Exactly.
Carladenise, this has been a pleasure. I feel like we could have a part 2, part 3. You're welcome back anytime you want. One question I have for our guests, can you let people know if they want to follow you, connect with you, where can they go to follow you and the work that you're doing within the U.S. healthcare system?
So on Twitter, I'm at CDenise, PhD, and LinkedIn, Carladenise Edwards. Pretty easy to find.
Nice. Awesome. Carladenise Edwards, thank you for joining the show. Really appreciate it. This has been a great conversation. So I'm just tickled that you would make the time for me and the show. And we just thank you for joining.
Thank you for having me.